I'm actually a cardiologist at Burch. It's a big congenital program in London, and we have a transplant program as part of that. If you follow the green line and the international registry, you can see that the outcomes for transplant for congenital heart disease have a high risk in the early phase, but in the longer term, after 10 years, the green line does better than the other groups. Now that may be in adults because these are younger patients, but if you look at conditional, so those that actually get through the operation, it's very clear that the adult congenital transplants do better. Again, qualify this by saying that these are younger patients. In the United States, Jacqueline Lamour has written up results, and she's found that if you compare it to the children, in the red line, and then adult ischemic transplants, that all ages congenital tend to do worse up to 10 years. After 10 years there's a crossover and then they do better. Our own experience in Great Ormond Street in London, in the more paediatric age range, is that about a third of our transplants, the greens again following the green line, are from congenital heart disease. And our survival in the recent years has been very good. So survival in a paediatric program for congenital heart disease is good. If you look at the international registry, again on the green theme, the green line, things aren't actually getting better over time. The early hazard phase is even worse in more recent cohorts, although with conditional survival, things are still better in the longer term with those adult congenital patients. So just a few examples. I'm tending to go through this fairly quickly because of time, but heart transplantation in transposition of great arteries, there are hundreds of young adults around who had a sending or mustard procedure in childhood who will all get right heart failure in middle age and will all need some sort of help. What are the results for transplantation? Well, just a couple of little papers showed that the results were reasonable, although surgically it is a challenge to do. But if you look at the bigger series, particularly the Jacqueline Moore American study, heart transplant for ascending or mustard of all the congenitals had the lowest risk. So one message from today is that not all congenital heart transplants are the same. Mustard ascending have a low risk. So where is the risk, and where is the danger? Well, from New York, they really show quite nicely that if you have to reconstruct the pulmonary arteries, and a lot of congenital patients need pulmonary artery reconstruction, then that was a very significant risk factor. Also remember, a lot of these congenital patients have had homograft material in the past, a number of surgeries, and sensitization is a problem. The different strategies to do it. The North Americans will just go on and transplant and deal with that. Other people will try and desensitize, and in Newcastle they have tried to do that. It's difficult as well. Do we have nightmares, or do our surgeons have nightmares? And do they have nightmares of any particular group of patients? Well, for those who don't know, this saintly gentleman is Francis Fontan, who of course described the Fontan procedure in his classic paper. The Fontan procedure, for those of you that don't know, is a way of replumbing the heart when you've got a single ventricle, so that the SVC and the IVC circulation can connect directly to the lungs without a pump in between. Going back to the big American study of congenital heart disease after transplant, Jacqueline Lamour looked at relative risk of death in the early phase, and she found that for congenital transplants, older age was a risk factor, ischemic time was a risk factor. But if you look at that hazard ratio for the Fontan, it was 8.6 times. So the Fontan procedure was a massively increased risk. You can see from this slide, the Fontan congenitals versus the non-Fontan congenitals do much worse. In Europe, that's the same here. These three curves at the top, the single ventricles who've had an arterial shunt, next curve a venous shunt, and the last curve the Fontan. That's from Rome. Daniel Bernstein, in a big multi-center study from the States, again looking at Fontans, showed that the Fontan patients were at risk in a number of different factors, and they had a higher mortality, but it's still the majority getting through, 77% survival as opposed to 85% of other congenital survival. They were more sensitized, had a bigger panel reactive antibody profile, and the deaths were more common from graft failure, hemorrhage, and interesting infection. The mechanism of the Fontan failure will probably affect the outcome, because the Boston group have shown that if you fail with a Fontan circuit with a impaired ventricular function, you do rather better than if you're failing because of protein losing enteropathy. So if you're failing because your pulmonary vascular resistance is bad, then you will do much worse at transplant with your single ventricle. The Fontan patients die because they have bad kidneys, they lose protein from their guts, they also lose lymphocytes into their chyle, and the majority by adult life will have a degree of liver dysfunction, which can often be cirrhosis. And they may be coughing up these casts as well. There's something called plastic bronchitis when they're losing protein into their lungs, which will increase their PVR. It's actually extremely difficult to do a cardiological assessment of PVR in a Fontan patient because not only are they in low output, but they have multiple sources of pulmonary blood flow. Pulmonary AV malformations may have a left to right shunt, right to left shunt, and also systemic venous collaterals. And my old mentor, Mark de Laval, who's professor of surgery at Great Ormond Street in the past, he felt that the Fontan circulation, as you can see here, leads to progressive pulmonary vascular disease because you've got a low energy pulmonary circulation which increases the impedance of the vascular bed, elevated lymphatic pressure, maybe small pulmonary emboli, chronic microemboli, which will increase the PVR. Interestingly, if you catheterize the Fontan patients before transplant and after transplant, you can see how inaccurate your PVR was, and they've shown that in Denver. You can almost double the estimated PVR that you got at your catheter before the transplant when you do the catheter after the transplant. So this is a race through, and I know we're short of time. So outcomes, the Fontan patients for congenital transplants are the highest risk. The early survival for congenital heart disease is worse than other diagnoses. After 1 year, survival is better than non-congenital heart disease. You can reduce the risk by careful evaluation. Now, some other things which I didn't have time really to go into, but listing and timing. The history is probably not very helpful in congenital patients. BNP in complex congenital heart disease isn't very helpful. You need to be preemptive and get in and do your transplants before liver or renal problems. If you talk to a C. Fassan in Newcastle, he will say his results are much, much worse in adult Fontans than in paediatric Fontans. Exercise testing is probably the answer in terms of when you list them. The VEV CO2 for most congenital, but for Fontans, it may be other things like a 6-minute walk or a VO2. And if you look at these little acronyms, it spells fear and hope, which probably sums up congenital transplant. Thank you very much.